All right, good afternoon, and thanks everyone who's joining another FLaNET webinar. We try to do these every month or so, and the goal is to educate patients, create a community of neuroendocrine tumor patients, and for those of you who were at our in-person meeting in Miami last month, I hope it was a useful meeting. We're going to try to do an in-person meeting once a year as well. So anyway, it's my pleasure to introduce Dr. Mohammed Alomar. He's a cardiologist here at Moffitt Cancer Center and specializes in cardio-oncology, which is basically heart conditions that are related to underlying cancer diagnosis. And Jill Sampson, who's a neuroendocrine tumor patient with metastatic small bowel neuroendocrine tumor and carcinoid syndrome, and also has a history of carcinoid heart disease, which is what we're going to be talking about today. So thank you both. I really appreciate you both taking the time to join us. So Jill, I thought it might be worth starting with you, and maybe you can tell us a little bit about, how the diagnosis was made, what your symptoms were, and we can start with that. This was over 5 years ago, right?
Right. Actually, 5 years ago yesterday is when I was diagnosed with my cancer. And then I saw you in April following that. And I was having all these different symptoms, but once I was diagnosed with a cancer, I just assumed they were all the cancer. And then I saw you and told you what all my symptoms were, and you had me do some simple tests in the office to check my heart. And the next words out of your mouth was, "I need to send you to a cardiologist." I was like, "Oh, do I need to go to anybody?" No, I have someone. We need someone who understands this. So I ended up with Dr. Syed, Danny Syed, and I went to him and he did a echocardiogram in the office, and then he sent me to the hospital to have a T-test and catheterization done.
So let's just take a step back. So you were diagnosed in 2019, but your symptoms had started about 4 or 5 years before that, correct?
That's correct.
And what were those symptoms?
I used to be able to run steps all the time. And where I worked at, I was always going up and down stairs. And I taught kids. And so I was always running with them on the playground. And I found that I couldn't even go up a flight of stairs without having to stop and rest for a minute to catch my breath. And then I could go up and forget running. That went out the door. I couldn't do that anymore. If I walked on an incline, any great length of an incline, it wore me out. I could hardly make it to the top. I'd be out on the playground with the kids and I'd get up to play a game or do something with one of them, and I couldn't do it. In fact, one day we were in the gym playing and I got so sick that I just laid down on the floor. All the kids thought I died. But I didn't know it was my heart, and at that point, I didn't even know I had cancer at that point. So I couldn't understand what was going on. And I sought a lot of help because we were living in the Atlanta, Georgia area at the time. And I went to 14 different doctors and I was so misdiagnosed. It was just crazy. I was diagnosed with thyroid. I was diagnosed with thyroid problems. I was diagnosed with POTS and basal vagal syncope. And of course, basal vagal syncope really is a part of this, but it took us forever before we got to Dr. Strasberg, and 2 simple tests in his office told him I need to see somebody about my heart. And he wouldn't even touch me with the cancer until we knew where my heart was at. And of course, I was there thinking, oh, I want to get started on getting fighting this cancer immediately, but it turned out we did it the best route. We took care of the heart first, then the cancer. So.
And you were also having carcinoid syndrome symptoms as well, right? Flushing and diarrhea?
Yes, very bad. And I would get sick and sometimes it was so bad it would make me pass out. It was awful.
And so I assume it was a CAT scan at some point that showed liver tumors. That was after an episode of abdominal pain?
Yes, that's correct. And actually, it was my OBGYN who said, you have fluid in your abdominal area, and this is not water retention. This is fluid. There's something going on. You need a CAT scan. So that was where the CAT scan came in.
Got it.
From her there, I got sent to a surgeon, and the surgeon sent me to you.
Right. So just to put this all together, so it turned out that you had a metastatic small bowel neuroendocrine tumor with liver metastases, quite a few. And these were producing hormones, including serotonin,
Mhm,
that cause diarrhea and flushing. That's carcinoid syndrome, which is
mhm.
typically associated with small bowel neuroendocrine tumors. And these hormones can also affect the heart valves, and Dr. Alomar can talk about that in a minute. Um, but just to continue your story, so you saw Dr. Sayad, one of the cardiologists in Tampa, and then you had surgery not long after that to replace the tricuspid and pulmonary valves, correct?
Within 2 weeks, it's probably about 10 days.
Got it.
It would have been sooner had I could have done it sooner, but I had responsibility I had to finish taking care of before I could do the
Well,
surgery.
2 weeks is pretty quick from echocardiogram to surgery. And you did have some complications, right, after the surgery?
Yes, I did.
You want to talk about that briefly?
Well, part of it is I had a bleeder after the original surgery. So Dr. Cardera put me back in surgery that night at 10 o'clock and opened me back up to fix that. And when that happened, my kidneys failed. As you know, it took a process of a few hours, but my kidneys failed, and I ended up on kidney dialysis for 2.5 months. But I'd do it again if I had to. But oh goodness, it was fun.
It's if I recall it, by certainly by a year after surgery, you had made a full recovery from,
Yes.
and you felt better,
Oh,
ultimately much better afterwards.
yeah. I really feel like I got my life back. I can go up and down steps. I can, do all kinds of things I wasn't able to do before. So yeah, it was great.
And at the same time, right, in fact, shortly before you saw the cardiologist, you had started sandostatin.
Yes. Yes.
That I assume helped with some extent with the flushing and diarrhea.
It did quite a bit.
And then you had a liver embolization,
Right.
um,
2 of them.
two of them. And that was about a year after your surgery, correct?
That's correct.
And you've been doing well since then. I think at one point you had a single tumor grow and you had radiation to that, if I'm not mistaken.
That's right.
And then you were on a clinical trial with PRRT.
Mhm.
And how often do you see Dr. Sayad for an echocardiogram at this point?
Usually twice a year, but this last time when I saw him about a month ago, he said I don't have to come back until I think it's December, maybe.
All right,
So I was pleased.
sounds good. So, Dr. Alomar, maybe I can turn to you. Maybe you can tell us a little bit about what carcinoid heart disease is, what causes it, how it's diagnosed.
Thank you, John and Ms. Sampson. That was a great story. Thank you. I always say here at MAPI, you end up learning a lot, as a cardiologist from patients with cancer because you probably did all the reading and all the follow-up. So you probably have a lot to teach a lot of us right now. So that was fantastic. Thank you for the summary. I have maybe 10 slides or so. I kind of wanted to keep the presentation brief so we can open it more to questions. So let me share this. Share screen, share here, share. Can you guys see my screen?
Yes, you can.
Yes.
Fantastic. Alrighty. So our program, just briefly, is a cardio oncology program. So I'm a cardiologist, but I mainly work with things related to cancer. So not necessarily cardiac tumors, but toxicities on the heart, so side effects on the heart from chemotherapies. And sometimes there are some cancers that can involve the heart. The neuroendocrine tumor is one of them, and the carcinoid syndrome. So our practice here at Moffitt, we have 2 nurse practitioners. We have a fellow who's training to be a cardiologist, and we're hoping to add more faculty, more folks in the future. All right, so this is just briefly to talk about the carcinoid tumors, where they are. They're usually rare neuroendocrine malignancies, come from these specialized cells called the enterochromatin cells. The syndrome, just like Dr. Strasberg said, The syndrome itself causes people to have symptoms like flushing and diarrhea. Sometimes cardiac involvement can happen. So these circulating peptides or hormones can get the heart valve and can cause carcinoid cardiac disease. So the carcinoid syndrome is typically when people are having symptoms from the carcinoid, so the flush and the diarrhea. When there is cardiac involvement, we typically call it carcinoid heart disease, and usually affects the valves of the heart, not necessarily the muscle itself much. So usually the valves. I'll show you a couple of videos later to show you what it looks like. Typically, 20% of patients with neuroendocrine malignancy develop carcinoid syndrome, and about 20 to 50 of those will have some kind of cardiac involvement, usually the right side of the heart. And kind of a little bit of a schematic here. So typically, these neuroendocrine tumors start to produce these hormones, serotonin. They can be broken down into smaller particles, 5-HIA for short. I could never remember the acronym. But basically, when this circulates into the body, it can get into the heart. Most of the blood, and of course, the blood that comes from the liver, from the intestine, sometimes from the ovary, if there's ovarian carcinoid, comes through the veins into the right side of the heart. And that's usually why we see the right side of the heart getting affected with this carcinoid stuff more often than the left side of the heart. We do see left side heart involvement in carcinoid in uncommon situations. And those situations are usually when there is carcinoid in the lungs. So usually the blood from the lungs goes straight to the left side of the heart. And that's how the left side valves get involved. And sometimes if there is a connection between the right and left side of the heart, if there's some kind of a hole, these circulating hormones can cross from the right to the left side of the heart and get the left-sided valves. So usually the more common side of involvement is with the right side valves, typically the tricuspid and the pulmonic valves. Okay, so these are all some of the symptoms that can happen with carcinoid syndrome: the flushing, the pleural effusion, that's accumulation of fluid in the lungs, some fluid in the abdomen, the diarrhea, and the edema, which is the swelling of the lungs. And there are some things that we can do to test for the heart involvements. The most common and early one typically is the echocardiogram. We abbreviate it transthoracic echo. But sometimes we check these, of course, the serotonin hormones, and there are a couple of cardiac markers, just like Dr. Strapper checks for carcinoid markers. There are cardiac markers that we check for to make sure the heart health is okay. Okay. There's one test called the MRI of the heart. What we can do sometimes is suspecting more involvement of these tumors into the muscle of the heart, not the valves, but we rarely do this. Most of what we do typically is this echocardiogram. Sometimes there's a specialized form of echo called the TEE, transesophageal echo. This test we use to kind of get a better look at the heart really from the inside of the mouth. So it's a procedure just like the endoscopy, if you will, but it's an ultrasound test that helps us see the valves better. The way we test for them, like we said, is with blood tests, echocardiograms, and usually these echocardiograms, we check them once in a while, so maybe once or twice a year, depending on symptoms, depending on how the valves look initially, okay? Survival is improved for patients who have carcinoid involvement of the heart because of the surgical techniques, because of the carcinoid, the drugs that the oncologists use here. And a lot of those patients with carcinoid valve disease will end up needing some form of surgery, sometimes to replace one valve, sometimes to replace two. And there are criteria that can help us determine when and how many valves to be tested. Okay. I'm going to show you, I hope this works here. Let me see if, so the picture, the video on the left side here, this is a picture of the heart that's upside down. So this is the left ventricle. This is the right ventricle. This is the left atrium. This is the right atrium. This thing here is the mitral valve. This thinner one on this side is a tricuspid valve. So this is the right side of the heart. And this is a, let me go back here. want to show you a difference between the normal heart on the left and the carcinoid heart on the right. Okay. So you see how this is very kind of stuck in appearance here. So this is a little thick. It doesn't move as well as this guy. Let me go back here and play this one more time for you. See how this is floppy and nice and kind of comes in and out. And this one on this side is more about like a stuck in appearance. So it's kind of stuck and it's not moving in, not moving out. So that's the carcinoid of the tricuspid valve. Okay, it becomes frozen in place. These are these peptides basically kind of freeze it in place, and that's why it becomes super leaky. But also it won't let a lot of blood go inside the heart too. So that was the carcinoid of the tricuspid valve, and this is another kind of view to show you. So that's the normal valve here, and that one here was the one who's kind of carcinoid valve. Let me put that one more time. See how it's kind of stuck there and all this blood in and out basically because the valve is super leaky. So that's how these valves look on an echocardiogram. And of course, the same thing can happen with the pulmonic valve. The pulmonic valve typically is the one that leads between your right ventricle to the pulmonary artery. There are medications that we can use sometimes to help patients with carcinoid valve disease. So some of them are water pills, a variety of those to help people feel better, maybe reduce the amount of swelling in the lungs, swelling in the abdomen. There are other medications that can sometimes help if there's heart dysfunction that can happen because of the severe valve problem. Sometimes people, especially if they live long with heart disease of carcinoid origin, can develop some heart rhythm problems that may require blood thinners. Luckily for us, there are a lot of smart doctors who sat together and came up with what we call guidelines. So this is basically a panel of experts who work, with this disease, cardiologists, oncologists. They came together and then came up with a document that helps us kind of choose the right treatment for the right patient. The most recent one is from 2022. That was the European Society of Cardiology Guidelines on Cardio Oncology, and they have a section on carcinoid heart disease. And typically, it's available online, free for you to read. The tables look something like this. So basically, they'll tell you, okay, this test or this medication is recommended. This test or that medication is not recommended. They have some details on this. So basically what they tell us is echocardiogram is a good test to do. Some blood tests like the natriuretic peptide that helps us understand the heart stress. And they told us basically to have a multidisciplinary team involves cardiologists, oncologists, and cardiac surgeons. And they help us determine when to intervene on these valves. Generally speaking, as soon as possible for those with severe valve problems and symptoms of valve disease. Typically in patients who have an expected left prognosis of 12 months or longer, we usually recommend those patients to go and get a valve replacement. If there are not a lot of symptoms, we still recommend people get these valve fixed as soon as possible because we know the longer that people live with valve disease that's severe, the harder it becomes to fix it later on. So you want to fix it early if possible. There are a couple of ways to fix these valves. And typically before we do this, we send patients to both an interventional cardiologist and a cardiac surgeon at the same time. The reason we do that is because usually you want to get some kind of a heart cath or an angiogram of your heart arteries before you do any open heart surgeries. Just because if God forbid somebody has a bunch of blockages, then the surgeon basically will go in and fix the carcinoid issue, and they should be able to fix the blockages at the same time, just because if you're going in, you want to get your money out of the surgery. So if there's a problem, you want to know about it before you get your chest open, basically. So there are a couple of ways to fix these valves, and there are a couple of valves to choose. So basically what they do is they take a prosthetic valve and they put it in place of the old valve. So in this case here, the old tricuspid valve is gone and there's a new prosthetic valve in place. And in this figure here, this is the pulmonic valve. So the pulmonic valve leads between the right ventricle and the pulmonary artery, and the new pulmonic valve sits right there. There are typically two types of valve. There's a tissue valve and there's a mechanical valve made out of titanium. The tissue valve is usually made out of either cow heart or pig heart. All right. The choice between the two depends on a bunch of factors. One of them is how old the patient is. The other one is patient's choice. The good things with the tissue valves is that they're usually easy to manage, so patients don't have to take a lot of blood thinners afterwards. The downside to those is that if you leave them 15, 20 years or so, they may deteriorate and they may need to be replaced or fixed. The good things about the mechanical valves is that they last typically longer, so 30 years. So I have patients who've had mechanical valves for 40 years or longer right now. Not so good things about them is that they may require, most all right now require strong blood thinners to be taken. So typically warfarin to make sure they don't clot. All right. So we typically use mechanical valves for somebody who's been diagnosed with carcinoid disease, let's say in their 30s or 40s, because their life expectancy hopefully is at maybe 40 years or so. Those valves, the tissue valves, typically choose for patients who are in their 60s, 70s, or 80s, just because we know they can last us 10, 15 years. And there are ways to fix them right now if they deteriorate. That doesn't require going to an open heart surgery again. If somebody has, like we said, a congenital hole in the heart, usually that is fixed at the same time as surgery. Okay, so really to summarize, the management of carcinoid valve disease requires serial testing, so echocardiogram and blood tests, sometimes specialized cardiac tests like a cath or a TEE or a specialized echocardiogram. There are a lot of details before these surgeries that the surgeons would need to work out with the oncologist to make sure we don't get a carcinoid crisis before we open somebody up. Once these cardiac issues are diagnosed, the treatment typically is a combination of medications and valve intervention when the symptoms are severe. These symptoms can be anywhere from difficulty breathing, gaining weight, chest pain or pressure, or some kind of arrhythmias. All right, so that's what I have. I'm gonna stop sharing and open the floor for questions and comments.
Thanks. That was a great summary. So a couple of take-home points, I think. Number one is that, I guess in the last couple of decades, probably we're seeing fewer patients with carcinoid heart disease as the treatments improve for carcinoid syndrome. And, of all the patients with advanced neuroendocrine tumors, it's probably more in the 1% range that develop carcinoid heart disease. But among patients with carcinoid syndrome, meaning flushing, diarrhea, elevated serotonin, it's probably more in the 10 to 20%, depends on how severe the syndrome is. Generally correlates with very high serotonin levels over many years. And we typically measure the serotonin as the urine 5-HIAA, which is a more accurate measurement than blood serotonin. So it's correlates with degree of elevation and time as well. And also another important point is that it almost always involves both right heart valves. So we've seen some patients who have had just one valve replaced and then need to go back and get another second valve replaced. One question I had is, there's increasing research on non-surgical valve replacement, in other words, going through an artery, and including tricuspid valves, but it doesn't seem like that's still considered a standard for carcinoid heart disease. Any reason for that as far as you know?
Yeah, just because the technology isn't really good yet when it comes to the valve. So usually the percutaneous or the valves that are done through a catheter, so typically through the groin or usually through the groin or the neck. The technology Dr. Strauss was referring to takes basically a valve on a catheter and advances it to the heart. And these valves typically come implanted on a balloon. So when you reach to the right place where you intend to deploy this valve, you inflate the balloon, that inflates the new valve with it. You deflate the balloon, and the valve stays in its place, and you come out. Okay. We've been doing something like this for the aortic valve, for regular aortic valve stenosis or tightening for over 15, 20 years now, and we've had excellent outcomes. Part of the reason we not very successful in doing this for the tricuspid valve is number one, the clinical trials haven't been as good when it comes to outcomes. The second thing is the representation. So most of the tricuspid valve interventions that are done through the catheter are typically in patients with that carcinoid. It's kind of hard to replicate or extrapolate the data from these trials into carcinoid patients. Right now, I think the indications to do these valves percutaneously is in those who cannot undergo a heart surgery. So basically, older patients who have a high risk of having complications from going to an open heart, or in situations where the patient just declines, they don't wish to have an open heart. The pulmonic is an easier work to fix when it comes to the percutaneous approaches, just because we learned from the pediatric data. So there are a lot of patients who are born with certain congenital heart disease that involves the pulmonic valve. And as these patients get older, to the 40s or 50s, there are ways to fix it with a percutaneous valve. It's been done for 20 years or so. I think we have better experience doing that in the pulmonic position. But with a tricuspid valve, I think we're still lacking in terms of data. I know our folks at PGH are leading trials right now to replace tricuspid valves in other indications using a minimally invasive approach, but still in clinical practice, clinical trial. So hopefully we'll have more data in the next couple of years.
Great. So hopefully we can open it up to questions if anyone else has any. Tammy, are other people able to chat?
Yeah, anybody can unmute, can send a chat or take off or turn their camera on. Feel free, please.
I wanted to ask you, John, before while people think about question is what do we as a cardiologist who do procedures on patients with carcinoids every now and then, sometimes minimally invasive, sometimes specialized echo. What should we do and how what to do to minimize like a carcinoid crisis in these patients? What's usually the practice?
So just to explain, carcinoid crisis is not a well-defined term. It generally means fluctuations in blood pressure, sometimes drop in blood pressure associated sometimes with things like flushing in patients with carcinoid syndrome, and often involves either anesthesia or manipulation of carcinoid tumors. In the past, there was a belief that administering short-acting somatostatin analog, in other words, short-acting octreotide, either by injection under the skin or infusion prior to procedures, could reduce the incidence of this. I think that's been increasingly questioned. Part of the reason is that almost everyone with carcinoid syndrome is on a long-acting somatostatin analog, so there might be less benefit from adding short-acting. So in our department, at least for surgery, we don't tend to administer prophylactic short-acting octreotide. The anesthesiologist has it available in case patients develop drop in blood pressure. And they use that as just one tool to correct drops in blood pressure. They also use conventional things like fluid and things like epinephrine, adrenaline. But that's a good question. When
I had my surgery, I know that they kept me on IV drip of it for, I don't know,
right.
several days, because they were afraid that would happen.
And that's the standard that we do for heart surgery. Whether it's necessary or not is, I guess, debatable. It certainly doesn't really seem to hurt. Octreotide is a very benign drug. But there have been some articles, at least in the GI surgery space, that question whether patients benefit from prophylactic octreotide.
I also have a pacemaker they had to install when they did my 2 valves.
Right. And I think they're starting to do that for all patients, if I'm not mistaken. Um,
Yeah, it's
you know
a
anything about
very
that?
good point. Yeah. So the issue here is that the cardiac wiring runs very close to the tricuspid and the pulmonic valve. So usually when there's an open heart surgery and you take out the valve, you put a new valve, and then you go on to the next one. There's going to be a lot of inflammation, a lot of manipulation around the heart wiring. So generally, everybody who goes to surgery gets a temporary pacemaker just because this can happen. And people typically are observed after the operation to see if they continue to need that temporary pacemaker. Every now and then, they continue to need it for days or weeks after that.
I have,
Yeah,
it
you
works
gotta do that.
97% of the time, if you want to know.
Another important point is that it's important to have a surgeon that really has experience with this and an institution that has experience. So we tend to send patients to a doctor in the Tampa area called Dr. Caldera. He used to be a Tampa General. He's at Largo now. He's just, done a fair amount of these. It's of course extremely rare. So by fair amount, we mean that typically means more than say 10. Yeah, because the number of patients who have surgery for carcinoid heart disease is extremely rare. There are probably no more than a dozen surgeons in the country that have had a reasonable amount of experience with this.
And he's got good bedside manner. I like Dr. Kadir.
Mena, do you have any questions or thoughts?
Well, Ms. Sampson, thank you so much for sharing your story with us, and Dr. Alomar for the discussion. The takeaway points for me are very similar to what Dr. Strasberg said. One is recognizing this as a complication from NET, but acting upon it in a timely manner. Many times I receive referrals for this ongoing cardiac issue, thinking that changing the treatment for the tumor is going to reverse it. And the cardiology team has not been appropriately engaged. So that's one thing that I think awareness will help with. And second is a cardiology team that has experience with NET, not only because of the technical aspects, but understanding that it's very different to repair a valve in a type of tumor that has a lot of treatment options looking forward in comparison to other malignancies where they may not offer a valve because there are other competing factors for well-being. So understanding that we should be acting on this and that we then can move on to other treatments for NET. So those are two points that come up in clinic quite a bit.
Yeah, and another thing is in recent years, there's been a drug, called telotrestat, Zermelo, that lowers serotonin, as do, of course, the somatostatin analogs, octreotide, which is sandostatin, and lanreotide, which is somatulene. So the somatostatin analogs are sort of the cornerstone treatment for patients with metastatic neuroendocrine tumors and carcinoid syndrome, because they both slow down tumor growth as well as inhibit release of serotonin. But we do have this other drug now that we can add on top of that called Zermelo, XCRLEMO. Zermelo, as far as we know, doesn't impact tumor growth. Its indication is for carcinoid syndrome diarrhea, meaning patients with carcinoid syndrome and poorly controlled diarrhea on sandostatin or somatulene. But it works by reducing serotonin secretion. It inhibits an enzyme in the cell called tryptophan hydroxylase. And so the thought is that it may inhibit development or progression of carcinoid heart disease. We don't really have any proof of that yet. There is a small trial taking place, I think at MD Anderson, looking at that. I'm not sure they're going to have a definitive result because you would need a large number of patients over a long period of time to prove it, and it's a very rare condition. But something to think about in some patients is, with very high serotonin levels is to start Zermello.
Thank you, John. I mean, what I wanted to ask you guys is, what's your, I don't know if you have like standard operating procedures for patients who come in terms of cardiac surveillance. I know at least I check an echo at least once a year, maybe every 6 months, but do you have any criteria for how to select patients for testing?
Right. So we select patients who have significantly elevated serotonin or 5-HIA levels. But there's no clear cutoff for screening. And then generally we rely mostly on echocardiograms. I know some institutions like basic naturopathic peptide or BNP. There's another very similar one called NT-proBNP. I don't know if you have do you have a preference among those two?
Yeah, I choose whichever is available to us here, which is usually the regular one, the BNP, the B-type.
Yeah. So, it's not a specific screening test, meaning, there's a decent number of false positives, I would assume. But it is probably good at catching things early. And one could rely on that as a screening test and then only do echocardiograms in patients who have elevations. And I know some institutions do that, others just rely on the echocardiograms. But
Yeah.
Anna, do you have any experience with blood test BNP testing for this?
What I've adopted so far is checking an annual urine 5-HIA, and if it's elevated past 2 times normal, I start a strict annual echocardiogram.
Right.
We want to catch this because you can find it before symptoms develop and start to think about medical treatment and prepare. So that's been my approach. I think BNP would also be a very reasonable way to add on to the urine test.
Right.
Yeah, I like the BMP just because it can help, so that's a blood test, basically, that every time there's some kind of a cardiac stress, it will go up. So it could be carcinoid, it could be a lot of other things too. So it's really not specific to the carcinoid. It helps us more when it's negative. So typically when it's normal, generally speaking, you're not likely to have any significant cardiac problem. If it's abnormal, then usually it's something that we take into account with the patient's examination, rest of symptoms, the echocardiogram, and it helps us understand where things are when you repeat it a year from baseline. So if it gets better, things are usually going in the right direction. If it gets worse, then you may want to get an echocardiogram sooner than a year. So we do something similar to patients who get some kind of breast cancer chemo. Typically, we check this blood test, natriuretic peptide, every 3 months or so. If it's normal, we don't have to do an echo. If it's abnormal, we check an echo sooner than every 3 or 6 months. So some kind of a hybrid approach.
Anyone else have any questions? And it can be in a chat function if you prefer. All right. Well, if no one has any questions, I think we'll conclude. I again want to thank Mrs. Sampson. Thank you very much for taking the time, and always nice to see you. Dr. Alomar, thanks as well. Really appreciate it.
My pleasure. Thank you so much for the invitation. Very nice to meet you, Ms. Sampson, and good to see you, John. And
Nice to see you too. Thanks
Bye.
everyone for your time.
Thank you.
have a nice rest of the day.
Mm.